Good evening, everyone. Thank you for joining us today and welcome to the podcast series Unpacking Decisions. This is a series that helps people be better informed and understand the nuances of a difficult topic and support their effort to participate in shared decision making. We do believe that this will ultimately help them arrive at decisions that resonate with their priorities and improve their quality of life. PatientsEngage is a platform that empowers people with chronic conditions and disabilities to engage better with their health and make informed decisions. We also advocate for more meaningful involvement of people living with long-term conditions in health system decision-making. February is Rare Disease Awareness Month, and this time in our monthly Unpacking series, we shine a light on the relationship between rare disease, genetics, and how it affects families. You can also check out our Lived and Leading podcast episode, which we recorded last month with persons with lived experience of rare diseases. I'm Aparna Mittal from PatientsEngage, and I am looking forward to the discussion today on genetics and rare disease, the role of genetic counseling, what is involved, where it can be done, and more. Our guest today is Dipanjana Datta, PhD in molecular genetics, and has 14 years of experience in the field of human genetics. She completed her postdoctoral fellowship from Virginia Commonwealth University in the United States and is a level 2 certified by the Board of Genetic Counseling in India. She's also the state coordinator in West Bengal for ORDI, which is the Organization of Rare Disease India, and a former member of the State Task Force on Rare Diseases. She works as a genetic counselor with many healthcare institutions across the country and is also a member of many genetic associations like the American Society for Human Genetics, the Indian Society, the Calcutta Consortium, and so on. So this is the 7th episode of the Unpacking podcast. And if you don't want to miss future episodes or want to catch up on our previous ones, do subscribe to us. In this Unpacking podcast, we speak with experts to support informed decision making. This is being live streamed. So if you post your questions, we'll try and address. Otherwise, we'll try and address them later. So welcome to the show, Dipanjana. Thank you for joining us today.
Thank you so much for having me. It's a real honor. Thank you.
So if we can start a little bit with some basic definitions, because I think it can get quite confusing for people to understand different terminology. Sometimes people will say molecular testing, sometimes people will say genetic testing, etc. So we can kind of explain some of the basic terms first, and then we'll start with the discussion.
Right. So I feel the problem over here sometimes gets that, whenever we talk about genetics, there's a lot of jargons that we use. And thank you, using your platform, we can also clear these jargons for many people for whom these might be a bit difficult. So just if we had decided to show some slides. So if you can just put on the first slide for us. So obviously, we know that information is passed from our previous generation to the next generation. And this information is in form of blueprints. So just like, we go to like before we make a house, we will have a blueprint. Or before we are trying to have a website, we will have a, code which will help to make the website. So human beings also have these codes, and these codes are what is passed on from generations after generations to generations. Now, as you know, there can be errors. So in human beings also, while these codes are passed from one generation to another, there can be these errors which are there, and these errors ultimately can cause some genetic conditions. So if we just go to the next slide, then, initially, like many think that genes are, something that will only happen, which is something at birth, like, in fetal life. But unfortunately, genes are something that are required by everyone throughout the ages. So if you just click, then we'll see that it is as important in the fetal life. Like just go on clicking, like, yeah. So it is as important in the fetal life, and something can be, if it's a gross thing, gross genetic problem, then we might be able able to see it in the fetal life. Most of the times this codes, there are 22,000 such codes, and these codes are also sort of packed in some car-like things which we call as the chromosomes. So the chromosomes are the broader genetic carriers, as we should say. Now these chromosomes might have a problem, and initially, so very early on in the fetal life we might see it. So initially when we see something very gross, we think of chromosomal problems in the fetal life. But as this particular baby might move towards delivery, the chances of these problems reduces significantly. It's not like it cannot happen, because it depends on so these 22,000 genes are there on these 46 chromosomes, and these 46 chromosomes are in pairs, so there are 23 pairs. Each of this pair from 1 to 22 carry a lot of genes. So depending on which chromosome has what kind of a problem, we manifest those kind of conditions, and they may be severe, they may be less severe, they may be life threatening, they may also be something which is life limiting. So a child may be born with them. But then it can also be that it is not a chromosomal problem, and as we are born, it's a problem in one of those 22,000 genes. And those can also be evident either in the fetal life, or it can be evident as an infant or a young adult, or even later on in life. Like, we feel that, oh, 40 ho gaya, to there will be no genetic conditions. But, Alzheimer's, there are different kinds of cancers, all of these might have a genetic etiology. So, and also what we are discussing now are these genes that can cause diseases. But there are genes also which we call as quantitative traits, like say our skin color. They are also coded by genes, but there are multiple genes. Say there are 10 locuses or 15 locuses controlling one, outcome. So these are called polygenic. So what we discuss clinically are the genes where it is so significant that if there is one change, it can cause a problem. But there are also genes which are, working together, like in groups. And there, if a subtle change happens, nothing much happens. But if many changes happen over there and interacting with the environment, it can cause a problem. So if we divide, what I mean to say is that there are situations where it is purely a chromosomal problem, which means it's a bigger problem where, they have the genes inside. There can be single gene problem, which all of these will be cause genetic or chromosomal issues. There can be gene environment interactions, which can also cause diseases. There can also be multifactorial, like infectious, but the infection happens to somebody who is more susceptible to a certain condition. There also, there is a background effect of a gene. So if we see diseases are actually either purely genetic or chromosomal. They can be susceptibility genes, or they can be multifactorial. And this can happen anytime in the lifespan. So if we also change, now if we are talking about the genes which we say they are clinically relevant. So now, if we have established that genes are basically units that are responsible for certain functions in the body, and if these units have a change, and this change is very rare, because there can be change, we are not exact copies of our parents, so these changes are normal. So changing in the DNA or DNA is dynamic, but then there are certain changes that can cause a problem. If we take an example over here, say if a CEO performs a mistake, the problem is huge. But if a clerk has a problem, then the problem is the effect of that problem might not be that huge. So depending on, the genes also, there are certain regions of the gene, if there is a problem, it will have a huge effect and may cause a disease. But then there are changes which might not really, there are changes, but they might be completely normal. And that is what makes a difference between probably you and me, because again, genes are a very small part of our entire DNA. And the entire DNA, if we like have an example, it's like, we can come like from here to the sun, we can actually travel twice. So that is the size. But the genes are only maybe not even 5% of the entire DNA. So that is why there is a lot unknown. But what we know, from that also, there is only a certain part which is clinically significant. So there is a lot that we also don't know. So hence many diseases, we cannot diagnose also till date. So if we go to the next slide also. So now when we say that they are passed on, so we also need to understand how they are passed on. So initially we understand that when the doctors used to see, they only used to see the patient, then investigations came in and we could only see the biochemistry, like you are measuring the proteins or the hormones or, the endpoints. But then, because the technology had advanced, we could actually see the single genes, the chromosomes, and now we could tell why there is a change in the protein, as a result of which there is a change in the person. So this level is called molecular. So we are from, we are going from the person, like from the symptoms. Say I'm saying fever. If you say
Right.
fever can be due to many reasons. Now, if we go and segregate that, okay, the fever is due to a bacterial one, fever is due to a viral one, or fever is due to cancer, or fever is due to something else. This is where we are classifying the fever, and that becomes molecular. And now if we see DNA and genes, then it becomes genetic. So that is the classification. Now, I already said that we have 22,000 genes, and these 22,000 genes are in pairs. But sometimes what happens that if there is a change in one of the pair, that can cause a disease, and that can be passed on also. So this is autosomal dominant, which means that there is a chance that even if there is one change, it is so huge that it causes a certain disease manifestation, and there will be 50% chance of passing that. And in that way, many people in different 3 generations will be affected. So these are inherited autosomal dominant disease. But most of the disease that we might also see may be that they are, the parents, so out of these two, the parents have one good copy and one bad copy. And because of the good copy, the bad copy remains hidden. And if a person marries another person who in the same gene has this kind of a good and a bad, then there is a 25% chance of a child being affected. They might have absolutely normal children, but they also might have children who are affected. So this is what we were talking about. So we all have 46 chromosomes. There are 23 pairs. Of this 23 pair, one pair will decide the gender. If it is XX, it's female. If it is XY, it's male. And 1 to 22 pairs is present both in male and female. So something can go wrong here. If it goes wrong here, it can be something which is spontaneous, which is not from the parents. And sometimes the parents might carry translocations or certain changes, structural changes, which are also making the parents absolutely normal because there is no loss or gain of the gene. But when it passes on to the eggs and the sperms, there might be an imbalance, as a result of which the child might have a chromosomal problem. Similarly, if we go to the next slide, we will see that we were talking about chromosomes now. If normally if we have a child, what happens, 23 from the father and 23 from the mother will fuse to form 46 in the baby. Now, if we go to the next slide, what happens is that during this period, there can be a problem which can give rise to a number of issues. But if we look at single chromosomes, then also in this case, what will happen is, you can see here, we have denoted it as a black and a blue. So half will come from the mother, half will come from the father. So black coming from the mother, blue coming from the father. And if the mother and the father are carriers, which means that they have one good copy and one bad copy, and because of the good copy, they have no symptoms, they are perfectly fine individuals, they might have children with all these 4 combinations, where good can come from the father and good can come from the mother and they are fine. Good from the mother, bad from the father, or vice versa, they are also fine because there's one good copy. But if both the bad comes, like both the bad from the mother and the bad from the father, then this child becomes affected, and he might be the only person in the entire family, he or she, who is affected. So in these cases, we call it as an autosomal recessive. So there are variations also. There can be X-linked, where the mutation is carried only in the X chromosome. So females have 2 copies, so there is no problem. They are mostly carriers. And male children, 50% of the male children, this this woman bears can have a problem. There can also be Y-linked disorders where the genes are on the Y chromosome. And there can also be diseases where nobody in the family is affected and this person has it, which we call as the de novo. There are other variations where whatever we were talking about is the nuclear DNA. There can also be another form of DNA, which is the mitochondrial DNA. The mitochondrial DNA has 37 or 36 genes, and these would actually can be passed on, and these can also have problems. And there are many mitochondria in a person that can also cause a mitochondrial disease. So these are the basics of the clinical genetics part of it. But then there is much that we don't know also. So many of it remains undiagnosed till date.
Right. Thank you. Thank you. I think you've explained all of the basic concepts. Just one quick question. One term that gets used at the moment is whole exome sequencing.
Yes. Yeah.
What is that?
So now if
the terms.
So now actually if we see a gene and we sort of take an analogy of a train. So a gene is say like a train. So the train has these buggies where you are sitting, correct? So they are the functional region of the train. So a gene also has certain functional regions from which actually the RNA is made, and these regions are the exonic regions. So they are the main regions which are responsible for the protein to be formed. But in between the exons, there are regions which are actually not coded into the RNA or doesn't get translated, but may influence the protein itself. And these are called the protein, the introns. So when we say whole exome sequencing, it means that for that person, we have taken all these 22,000 genes and we have taken only these coding, these exonic regions, the buggies, and left in between the introns, the linker regions are left, but we have only taken the buggies and we are sequencing the buggies. So if there is something in the in between regions or the introns, that is what we are missing. Or we are missing, say, the first part of it, like the engine part of it, or the last part of it, the upstream UTRs and the low stream UTRs, which are probably regulating the gene. So they are the regulatory regions of the genes, which we are probably not getting when we are just looking at the regions which, the exonic or the main protein coding regions. So because most of the mutations that, like most of the mutations are very, very rare changes in the gene. So most of the mutations will ultimately affect the proteins in some way, like either functionally or structurally or, quantitatively. So in those cases, we feel that most of the mutation will be in these regions which is actually coding for a protein. And the regulatory regions might have less of it, or the implications of mutations in the regulatory regions might not be influencing the disease manifestation in a huge way. So when we sequence, when we have to sequence for a patient, if we are looking at these exonic regions, we call them as whole exome region. And when we take all the exon and the intron and all the UTR regions, we are saying the whole genome region. So that's what it is.
Thank you. So then let's come to the scenario we're talking about, right? We've explained the background information. Under what circumstance will a doctor prescribe a genetic testing?
So see, ideally, genetic testing is prescribed by someone who is practicing in some way genetics or is very closely related. So say, right now, though everything is not ideal, but, patients will come to fetal medicine, neurology, nephrology, cardiology, orthopedics, and the doctor suspects a genetic condition, because there are certain conditions where we know that it can have a genetic etiology. The doctor or the geneticist will start ordering these tests to understand the basic cause of the disease. So maybe the cause is known, the basic pathway of the disease.
Right. And why is this test important? And what is the outcome of the test?
So, if we say importance, there are, again, we will divide the importance into three parts. Number one, first is we have to have the suspicion. If there's a suspicion, then we have to have a diagnosis. So right now, even if we do a genetic testing, the diagnosis is only in 30 to 40% of the cases. Like if I have to give a genetic diagnosis. But if I have a genetic diagnosis, it also helps me for that child, for the management of the child. So we can answer questions like, what is the prognosis? What is going to happen? Will there be a regression? What would be the natural history of the child? And then, like in most of the cases, we cannot change a gene, but what we can do is plan the management around. And also the parents might have a idea as to what is happening to the child and what will happen to a child. So it's like a goal setting for them. Also, in about a few cases, we do have medicines or supplements that can actually change the natural history of the people. In some cases, these patients can have management in form of surgeries like transplants. In some cases, management can be in form of small molecules like, supplements like growth hormones. There can be supplements like, dietary supplements. There can be supplements like, say, iron chelation, so that that can help to reduce the burden of the disease or can help in management in some way. There can be supplements like, we use insulin. So even in rare disease, say an enzyme is not working, there can be these enzymes which are given to the child, the enzyme replacement therapies. Or right now we have a series of DNA modifying therapies where, it's like a patchwork. And, even if there's a mutation and we were talking about the protein is not being produced, but maybe a form of the protein which is less efficient but nonetheless being produced, so that the disease manifestation is, the load of the disease is lower or it does not progress. So these kind of managements for a group of disorders also can be planned. Very importantly, if a genetic condition is inherited and it's a hereditary genetic condition, and this couple plans to have more children, or somebody in the family of the couple wants to have children, they can be aware and they can actually prevent more children, or they can prevent or plan and have a healthy child. So I think genetic testing implications are majorly in these three regions.
Okay. And currently, where does somebody go for genetic testing in an Indian setting?
So in Indian setting, we have testing both in the government space and in the private space. So many of the private hospitals, there are private labs. So the doctors can directly give to those private, like, ask those private labs, give the contact to the patient, and the patient does the needful. Sometimes the hospitals are tied up to these private labs who can give. Some private hospitals have their setup by themselves. Some government hospital, because of the National Rare Disease Policy right now, also has a setup which they have on their own, and they are giving these tests. So right now it's heterogeneous, but still it is not as much as available as it should be, or it's needed, I guess. Yeah.
And all of these labs are still in the big metro cities, or
So they are not even in the big metro cities. So their sales and marketing is in all the cities, but mostly the labs are concentrated into either south of India, north of India, or west of India. Yes.
okay. So you don't have in the east.
East, we are probably having one, like we are, one
Um,
very new lab has started. So yeah, let's hope we have one.
and so there's a term called genetic counseling. If you can
Yes.
explain what it is, and is genetic testing always accompanied by genetic counseling?
So let's first understand what happens when you meet a geneticist. So basically, when you meet a geneticist, you are either referred by. So in an ideal situation, there are two aspects of it. So you come before the test, we call it as a pre-test counseling, or you come after doing the test. So it's a post-test counseling. All right. In Indian scenario, most of the patients we see are post-test. All right. But in an ideal situation, what should happen is that the patient should come pre-test. Why? Because number one, you are setting a goal for the patient. So, say for every condition, you need to take a series of histories. The history would be the clinical history, which maybe your clinician has already taken, or there is some suspicion, hence they have sent to you. So from that, you also take the past family members' history, a three-generation pedigree. You observe the dysmorphisms in the child or the patient or the individual or the family members, if there is. You also ask certain pertinent questions, and then you first explain the patient why these are happening, why the patient is there. Because in the Indian scenario, most of the time the patients से कि हमको बोला गया है यहाँ पे आने के लिए, which literally translates to we were just asked to come, and we don't know why we are here. So initially, in some cases, for me, I start most of my sessions saying ki, do you know why you are here? So because that is something that I have seen, that in many cases they don't realize why they are here and what is the utility. So we try to break that down first. And after that, the next thing that we would do is take all these histories and try to explain to the patients that why we are doing what we are doing. So say we are taking an example of a case where the yield is very good, like 60%, 70% in the sense of the genetic etiology. So
What
if
does
I
it mean,
understand,
if you can?
so it would mean something like, say, a person has come who has multiple fractures in their bones, and for no reason, like, everything else is fine. So probably you have a suspicion of osteogenesis imperfecta. Now, if you have a suspicion of osteogenesis imperfecta, we know that the chance that we will get something genetically is very high. All right, and then you go deeper into phenotyping and you see this person has a blue sclera, and you ask more questions and you look at the body parts and you look at the person, and you form your own. So it's like, you have a suspicion and you work on the suspicion, and you also on the way try to explain to the patient what you are seeing. All right, and on basis of that, you explain to the patient what is going to happen.
Right.
So the natural history, and if they opt for a genetic testing, which is actually also gives us to the question you were asking, that does every counseling session follow with a genetic testing? And my answer would be no. If I'm doing a pre-test, it would depend on why I'm seeing the patient and uh, what is the cause to see the patient. And in some cases, if we can make a diagnosis and it has of no other value, and I can make a clinical diagnosis, we might not also opt for a genetic testing. But in some cases, if we need a genetic testing, and if we want a genetic testing and we need a definitive diagnosis, which is always desirable, then we might be going for a genetic testing. But then what is very good might not be best. So for the patient, it might be a financial barrier. For the patient, it might have other implications as well. And in most of the cases, if I diagnose, the next question is, do you have medicines for it? Correct. So we are also going to set that goal that no, a testing will not mean that I'm having a diagnosis and giving you a medicine.
Right.
But it also sets the goal of that what will be the natural history, whether knowing the gene or the mutation adds to the therapies or the management, or anyhow I can do a therapy and a management, and it's just an additional information. Like, if I give you an example, if I'm diagnosing, say, Gaucher disease, my enzymes are giving me that it's a Gaucher disease.
Right.
Do I need a genetics? Of course I do. But do I need a genetics for treatment? I don't, because I already know that it's the enzyme is not there, and the diagnosis is right there. So
So then
so
what is the role of that genetic testing then?
the role of the genetic testing is also genotype phenotype correlation, which is a very controversial topic, because in most of the cases, as far as the Indian setup or many setups are concerned, genes right now have an expanding phenotype. They, even if we think that this is what they are doing, this mutation is doing this, but in some like it's not. But in some cases, at least we can predict. There are, and these predictions are based on the statistics of that variation. That how many patients, what have we seen for that patient, and then the clinician can actually be informed. Then you can be ready with your interventions for those, and you can also set up the goal. Also, if they want to have a second pregnancy, that becomes extremely important, because enzyme testing can be done prenatally, but it is again not the ideal test. And in many cases, enzyme testing is not available also for all conditions.
Mhm.
So that becomes important. But also in some cases, we associate severity with the type of mutation, and each gene has a mechanism of disease.
Right.
If I may say, it's like, say, you can have fish, and you can cook the fish with mustard oil, or you can cook the fish in coconut oil, right? But the two preparations will be different. So if
Mhm.
I know the mutation, sometimes, I know whether it's in coconut oil or it's in mustard oil, and I can take my, interventions accordingly. So that's exactly what sometimes the clinician will do and help to update. In some cases, certain medicines can work, especially this is true in many neurological conditions like epilepsies. There are certain drugs that will work. Even in cardiology, there are certain drugs that will work, there are certain drugs that will not work. Then there are also, in some cases, we know that if there are two mutations, like, I said, it's in pairs. So if it is both the pair are affected, then the severity of the disease is something. And if only one of the two pair is affected, then the severity is something else. We see this in hyperlipidemia. And
Mhm.
again, my management will change, my natural history will change. So if I know these mutations, in many cases, it can be very useful. But in some cases, it might not add anything extra also. So it
Mhm.
will depend on the patient after they realize this entire thing, to decide whether it is something that will be relevant for them. If it is relevant for them, then they will probably go ahead. But in many cases, I work in a hospital which is a tertiary care hospital, and it's a trust hospital, and we have people from very low financial background. And in these cases, many a times, we they will not be able to afford such testings, even if it is right now very affordable in like compared to what it was even 5 years before. But
Mhm.
they can't afford. So here we triage. It's also a kind of triaging that we do. Whether it will actually benefit. So I'm seeing a GDD with a ID, and this person will, like, there is no other thing that is there. So in such cases, and if the person does not want to have a second baby, or there is no other implications, and I can make a clinical diagnosis that it's not one of those metabolic conditions where I can intervene by certain clinical or biochemical tests, I wouldn't push the patients to do more testing, or there's no need to do a
Right.
testing.
Right.
So similarly, if I'm seeing a neurofibromatosis, it's something that you can diagnose just by looking at a person or looking at criteria. Of course, genetic testing adds to it. We will not say it does not add to it. But then if it's just a diagnosis that needs to be given, you can also give a provisional diagnosis to the patient and wait whenever he's comfortable to do more testing. Or if he doesn't want, then there's no test. So yes.
Right. And does the testing always include testing the entire family, or is it enough to just test that one person?
It will again depend on what kind of what I'm getting. So
Mm.
if I'm looking at a trisomy 21, and that
Mm.
is because of there are three chromosomes over there, there is really no need to test anybody else in that family. So similarly, if I'm looking at certain conditions which I know is de novo, maybe in those cases, if it's a cost restrictive setup, I wouldn't need to test. But say I'm looking at something like a SMA or a DMD,
Mm.
and I can see a family history over there. And this is one sister who is having a child, and there's a second sister waiting in line and is pregnant. Then obviously we will go for the family testings, and those would be targeted testings in those cases. So the answer would again be, it depends on the family and the mutation and the condition that we are looking at.
Right, right. So, my coming back to that question of is it accompanied by genetic counseling? So the point is that we anyway have limited centers where we
Yeah.
offer genetic testing. Um, do all centers, government, private, etc., offer genetic counseling? And if not, who addresses that gap or that
So,
service?
so if I have to just give you a statistics, so let's like the stats is not based on any census. So I just might just say that this is a hypothetical stats which I am giving you. So say we are saying that rare diseases is 1 in 2500. But if I'm looking at Down syndrome, it is 1 in 600, correct?
Mm,
So then if you pull India's population, 1 in 600 means how many patients can be affected. Um, in that version, if I just say the number of genetic counselors and clinical geneticists we have, it does not even adding them together also, it does not reach 1,000.
mm,
So if that is the case, then obviously there is a huge gap. You can say 1 in 600 with billion of a population with not even reaching 1,000 people. Uh,
mm,
like bringing in both the communities, a genetic counselor and a clinical geneticist. So if we have to say, then we right now need a geneticist, be it a clinical geneticist or a genetic counselor, in 1 in 6 million people. So that is each person counseling. Of course, that is not there. So of course that's not there. So right now, what is happening is that we as people, it's not ideal, but we are getting a lot of post-test counseling, which means that the test is already being done at the by the specialist. It's either the neurologist, the nephrologist, the cardio, the super specialist person, the fetal medicine, the gynae, whoever. And if there is a difficult report, then we are being sent to counsel. So, yes, the ideal situation that there has to be a pre-test, people understand, and there has to be a post-test is only in few privileged places. Also understand that even access to these super speciality is not very
mm.
even across the
Correct,
country.
correct.
Yeah. So, so right now, I would say we haven't still yet reached that point where so many counseling is needed. Saying that, many of these at the point super specialists, they have educated themselves and they are counseling and for certain cases, because these patients will also not travel too much or go to places. Also, there are many private genetic labs offering for telecounselings, which is reaching out to many people. Many
Right.
of the clinical geneticists and genetic counselors are doing telecounseling. So if there is a contact, if there is a network, then they are actually referring to these networks, and things are happening. Many are referring, but you understand that for a person to travel 500 kilometers to see a geneticist is sometimes not possible also. So, yeah.
Yeah. Um, okay. So, but at least I guess it's a start that there is now telecounseling as well. And so hopefully over time we shall see, this progress.
But saying that, telecounseling is not an ideal way. It's not an ideal way. Though I know that we are very comfortable with it right now
Mhm.
because of COVID. But genetics is one thing which I prefer, especially counseling part and the diagnosis part also. It needs to be in person because there's a lot of human factor over here,
Mm.
and when you're talking over the phone, somewhere that is compromised for sure.
Right, right. So that kind of brings me to my other bit, right? Like when a family goes in to see a genetic counselor, what should they be expecting? And how do you also, maybe we'll talk later on how do you counsel them after the results, but when they first go in, what should they be expecting? What should they carry with them? Do they need to, what do they need to bring along?
So in India, they just fall from the tree that they are there. Nobody tells them anything, like many patients. But yes, some patients, they are aware and they come. So what we actually would like people to bring are, whatever they have done so far. So we do take a lot of time to see a patient because we have to go through all the files so that we can get the information right. All right, because we cannot trust the patient narrating the whole story, and they might miss points, or there might be things which I want to see and they did not tell me. So,
Right.
number one, one thing is mandatory is to bring all the past, whatever doctors they have seen. If they can bring it, then it is something that we would really cherish. Second thing is that when they come, they need to also ask about their own family and be aware about their three generation family because, in India, though, everyone knows about everyone, but there are sometimes, we see, especially the female knows a lot from the house. The man even can't say whether the mother has a miscarriage or not, or is not willing to say. So,
Right. Right.
so
And there's
that's,
also, I think one of the things we found was that the we were not very good at, right? I think now we're getting better at acknowledging certain conditions and issues, but before that, we often did not. So, or we never got a diagnosis to say why somebody passed away or what happened, right?
yes.
So you
Yes,
don't really have a
and
say.
also there's a lot of denial, like if you don't ask the question, they don't answer. So the first thing, many of them will say, "नहीं नहीं, हमारे family में ऐसा कुछ नहीं है. We never had anything like this in your family." And then if you ask, they will say there were 5 neonatal deaths, 6 sudden heart strokes. Okay, and they will say, that is that those were though due to infection. It was old age, so they were due to infection, and it might be, we don't know, but nonetheless that history exists, and it fits in your profiling which you are probably doing. So that is there. So knowing a bit of the family, bit about the family helps for sure. We take a 3 generation family history, so knowing as much helps. The patient normally, I don't know what they expect, but at the same time, what they have in mind is a lot of uncertainty. If you tell to a person that it is genetic, go and see the genetic person. There's a lot of pressure, like social pressure, I would say, on you that, oh my God, because genetic and hereditary is almost synonymous, and there's a
Right.
lot of guilt they come with. So I feel our first job is to, address and make the people comfortable so
Hmm.
that they can actually narrate their own stories. But because, unless they understand why we are asking the question, it also becomes an interrogation. Why I'm saying, say, in India, in most of the places, even with educated people, that not everything is told very openly.
Right.
All right, and many families have like issues saying. I can give you an example. Like I had a woman who was married to a man, and she came crying saying that they never told me that they have a bleeding disorder in the family and it's hemophilia, and when we married they never told me this. So this is the situation. So it's not just the woman's family hiding, but it's a man's family also hiding stuff. So sometimes when the doctor refers, and these kind of things are triggers for them. So understanding these triggers and comforting them before, and putting the guilt down is one
Hmm.
of the first motives of a counselor to do, so that they can talk and we can get a genuine history out of it. So in your doctor's consult, it is maybe a 10-minute consult, like you tell me this is the disorder, this is done, and it's gone. And you
Got
say, go and see the geneticist. And there, between that doctor saying go and see a geneticist and then coming and seeing a geneticist, there is a lot of things going on in the mind.
Yeah.
So I feel one part is the science, the other part is the sheer human emotion that comes when you see a genetics person. So
Right.
our job is also to address that, calm it down, pull out the information, and then help them manage and accept. So that's how it should go.
Right. So, and as part of the genetic testing, most cases you're saying you're doing the counseling after the testing has been.
Yeah, right now, yes, right now, yes.
And just so that to complete the information for the testing these days, is it based on a blood sample? Is it based on, as you see in crime thrillers, a lock of hair? What is the?
So it again depends on what you are testing for. So yes, most of the samples are blood samples. We do have fetal samples also, like we have the product of conceptions, which is the abortus. We sometimes have amniotic fluid or CVS samples or the tissue from the placenta. If we are looking at cancer, we will have tumor tissues also. Sometimes if we are looking at, say, conditions like mosaic condition, we also have skin biopsy samples also. So it will actually depend on the what we are looking at. But yes, most of it will be blood, unless it's a special case and where we will be looking at other tissues.
And at the end of the test, they get a report. What is the output that they would typically get?
Yes, so they will get pages after pages of very complicated information which comes up, and our job is probably to tell them what is what, and from there, again, it's so like if I have to say, so see, if the pre-test is done very well, the post test actually goes very well. All right. But problem is, as I said, we are doing pre-test more. So we actually have to start from the pre-test, like even if we have the report in hand. All
Right.
right. So because the expectation over here has some issues. In the
Mm.
sense, I will give you an example. So
Mm.
we had a doctor from a rural area, and the doctor had told the person that you do the test and you will get a diagnosis.
Mm.
All right.
Mm.
And there's a fundamental problem with that.
Mm.
Why? Because, a genetic test may or may not give you a diagnosis. As I said, it's only 30 to 40% of the cases where we might be able to have a conclusive diagnosis out of a genetic report. So
Right.
if I tell the patient and, they are seeing, they are actually seeing they are actually seeing a skeletal issue, then so I'll give you the case. It was basically a skeletal problem which we were seeing in the child.
Mm.
Nonetheless, whether the genetic report comes or not, does not come, it's still a skeletal issue in the child which was there. I'll not go into the details, but it
Right.
was a non-lethal skeletal issue. All
Mm.
right, so the counseling over here, could have been that yes, in most of the cases, it is a genetic case, but we may or may not find a reason. Nonetheless, the child has a skeletal issue, and you
Mm.
are counseled on what you are seeing prenatally, and you are also counseled on what you are not seeing, right? But unfortunately, these patients were told that no, if you do the test, you will know why this is there.
Right. Mm.
And so the expectation was that the report will yield something. And now this report came normal. So the patients, they were saying that, oh, so then I don't have any condition. The fetus is fine. So,
Mm.
you had to bring it back to the point, but you are still seeing that the bones in the fetus are, not, as it should be. So obviously there is
It's
a
not a
problem.
genetic
Not
condition, but there
fine, but
is some
no,
other
it may,
problem,
it
right?
may still be genetic. It may still be
It
genetic,
may
but
still be
we
genetic.
might not know about it. We might
Right.
not know the cause. So, and we might need to do additional tests. We might also, even if we do additional tests, we might not find it also. So, there are many things that can happen over there. So we might want to do an autopsy for the fetus if we don't find anything. So
Right.
but the expectation of the patients were that if we do the test, we will get an answer and we will base our entire decision on that answer, which was why pretest was needed for them. So now when we counseled them, they realized that okay, fine, so not every test will give us everything.
Mm.
And their answer was that what happens if I again conceive? Will this happen again? Now, with a normal report, how do you counsel this patient?
Mm.
Right. So that is where, the post tests become very complicated. And you have to assure the parents with different ways, and you have to bring them to the point that it is still might be a genetic condition, but we still don't understand why this is happening. And it is for human beings itself. When you don't have an answer, acceptance becomes very difficult.
Very
So,
difficult.
your genetic report, even sometimes if we cannot do anything, it also gives you closure कि ये हो रहा है.
Correct, correct.
So sometimes that also does not come. So here the role of post-test becomes extremely important, and so does when we get so many ambiguous reports, to explain this to the patient, to handle them to realizing, accepting. And of course, if there is a diagnosis, for the natural history, the progression, the management, how it implicates their family. And we have to understand that whenever such diagnosis comes up, it's never just one individual.
Exactly.
It's the entire family.
Right.
And there's a lot of taboo with that. So, so when we are reading out the report to them, it's just not that you have a diagnosis. It's a lot of things you are looking at, and you also have to look at the social, financial.
Right.
Like, I can just say that, oh, you have got DMD, so there's a 2 crore drug there, just go and have it. In the Indian scenario, that's not possible. I cannot say go to the trial which is happening in UK because you can get a medicine there. So this is not happening, correct? So if I'm giving a diagnosis, then it's also my responsibility to tell them, uh, these are the places, this is what is happening, these are your options, this is how you are going to go forward. So,
Right.
and then they go and meet the doctors, the specialists, also helping them with the patient support groups, because they won't know. They
Right.
feel lonely. So
Right.
how do you help them? So you help them with giving them a community so
Right.
that, they realize that they are not alone.
Right. So, you said that sometimes you don't get um the results are not very clear, right? So
Yeah.
in general, what is the level of accuracy or of these tests, and does that vary by the kind of rare disease we're talking of or the type of genetic test we're talking of? And is there any point of testing again after a few months, after a few years, because obviously things evolve, right? So,
So yes, so the first question is, the yield depends on the test we are doing, definitely. The diagnosis made, the genes and the test we are doing. If we are looking at exome sequencing, then most of the variants are inconclusive, right? For many reasons. Number one, in India, we are not publishing as high we should. In India, we don't still have a database, though it's informing and probably we will have
right,
it very soon. But
right.
it's still not publicly available. Let's put it that way.
Hmm.
And there are a lot of issues with different labs following different pipelines and not all labs having the same standard.
Hmm.
And the interpretation is very person specific. I would say like pipeline specific. So uh, there can be variations for sure. So that is why the data sometimes needs to be reanalyzed depending on like if we are getting more phenotypes. Say I have tested somebody at 2 years when it was only epilepsy. But
Hmm.
later, at 5 years, I'm seeing more signs. I'm seeing more symptoms in the child, and but the data is still there, and I would first like to relook at that data, and if I don't find anything, as you said, because of the advanced technology and the advanced pipelines, I might want to test again. But it will depend on how strong my genetic suspicion is. Like if it's not too strong, then why test? Sometimes we are getting these variants of uncertain significance, which means that it may be a gene of interest and we have got a change, but this change was not reported in anywhere in the world or did not have enough scientific evidence to actually term it that disease causing. So we sometimes would relook into these genes and variants later for the patients and see whether the significance has changed or whether it was also, like whether it has become benign or useless.
Right.
So we had one such example where actually we had a family where initially when we did a testing, it was just the first child, and they already had a second child, but the first child was at that point just affected with nephrotic syndrome, and we did not find anything. But what happened after 3 or 4 years, the brother who was very small when this child was affected also got affected. And then we realized that no, there had to be something, that we are probably not we are missing something. So we retested. And when we retested, we actually got a variant because, there are new genes, new variants, new locations which are coming up. So that is why in those cases, we might be able to give a diagnosis later also. So, hence I said, the genetic testing is a very dynamic concept. And yes, at times we might need to look into the data or retest later.
Right. Right. So you also said that, sometimes if you're testing 5 years later, you may test with the existing kind of whatever sample or, that may be there. So currently, what are the guidelines on that? How long are you allowed or are labs allowed to keep the samples and the tests?
Samples are not there more than 3 to 6 months, so they are supposed to destroy it, but the data stays. So the data is, of course, there. So, and the lab is bound to give the data to the patient because it's the patient's data. So there is no second opinion about it. Though in India right now, the awareness of our
Mm,
patients towards their data is very, very low.
mm,
And that is something that needs to change. But yes, in general, maybe the clinicians, the good labs, they are very, very careful about it.
mm.
But frankly, the awareness of the patients for these data are very, very low. So yes.
Right, right. And also, so there's, I mean, yeah, people don't understand data privacy rules as well, right? So, and they don't understand how this impacts them either in terms of what they share with relatives. So when you do the counseling for them, do you what is it that you're seeing as patterns, or what would you advise patients? Are they supposed to tell as many of their extended family because, it's a potentially many more may be impacted, or are you advising them to keep it to themselves, or you're letting them take that decision? How does that whole?
So in India, this is very tricky. All
Mm,
right. So it's very tricky because the acceptance of a genetic disease is not um, very high or very good, even in the educated entire lot of the people.
mm, mm,
So, see, when a patient comes to us, our loyalty lies with the patient for sure.
mm,
All right. So,
mm,
if the patient is comfortable, we ask the patients to take a decision to say to other family members. And but ideally, what should be done is with the consent of the patient, we should be sending letters to the other people. All right. But again, it's their choice. Like it is a matter of choice that whether I want to investigate my DNA is absolutely my own choice. I may or may not want to do it, right?
right, right.
So again, here the boundaries are very blurred, I would say, for a very simple reason. Because in India, number one, if it is genetic, we many of the times the patients are not comfortable to tell to their siblings or their other family members. But then there are proactive patients also who are actually saying to the other people and bringing them in and saying that this needs to be done.
Hmm.
So, so it's both ways. Like I think India right now is maturing to this idea, and but our loyalty and our everything lies to the patient and their consent. So if they don't consent, then we obviously cannot go beyond that.
Right, right. So, can you give an example, a couple of examples, so that we address that whole emotional aspect and the, how 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 can families handle this information once they are diagnosed with something, or even if there's uncertainty, because sometimes uncertainty can be even more difficult than, a clear diagnosis, right? So what is your advice to people in terms of, what to do with that information and how to process it?
No, I think as individuals, we have different ways to process an information. So I'll give you two examples of this. Actually, like something which is very close to my heart. Two families. One of these families, they are not a very educated family. The father works at a leather, tannery, and the mother is a housewife, simple housewife. They had lost two children, and I was looking at it after the third child, and we diagnosed them with a condition which was HLH. All right, so it is a condition where your own body molecules turn against you after a fever, and the child just slips into it. So once and we had made a diagnosis like almost at the terminal point, like when I had met the patients. The child was already on the verge of passing, and unfortunately they had another child which was just born. All right, and uh, as a result, we tested that particular child, and I was very upset because that baby also had that particular mutation, and we knew this baby in the lap will also fall sick. Okay, it was just a matter of time, and we were trying to save that particular baby, but they were not very financially in that zone. So this child passed off, and next day came when we were following up with the little child, and eventually after 3 4 months this child also slipped on to have the condition. And I as a person was certain cases just get to you also. So this was one of those cases where I was feeling very bad for the parents because it was their fourth child. And they had, one was a normal delivery, and then they had C sections, because you know how it goes that, oh, normal बच्चे में ऐसा हुआ तो C section कर लो तो बच्चा healthy रहेगा. So this was their third C section.
Oh.
So they were, and the doctor had told that, they cannot have another C-section, or they cannot have another child, blah, blah, and then all of that was there. And literally, I was feeling, when this last baby was there in our hospital, I actually was feeling overwhelmed by it. All right. So, and I was talking to these parents, and and they were very nice to me. They were like, no, you gave us a diagnosis, you told us, you helped us, you tried for this child, the entire hospital, the entire doctors tried for this child. We are very grateful. And I actually blurted out to this family that how are you grateful when we could do nothing? We ultimately did not save this child. We couldn't, like, like, how are you grateful when your child is here? And he said, no. And see, these are uneducated people. But, this guy gave me a very important lesson in my life at that point. So he said that, madam, when we got a diagnosis, we never realized why this was happening with our children, and we thought of a lot of things, and we wanted to try a lot of things because we wanted to, of course, save our children. But when we got a diagnosis and we understood that it was beyond us, and these were God fearing people, and they said that, when we understood it was beyond us, but we also understood that this was happening to us only. So God must have chosen us for this, and, for this pain, and we accept the pain. But ma'am, our child was well when you told us that this was happening. So what we did was, we knew we would lose this, and we did not have this in our mind that when are we going to lose it, or we were not scared when the child started falling sick, because we knew this was what will happen. So mentally we were prepared, number one. And whatever time we had with this child, we made sure that we could actually live with him and have our memories, and not actually worry what will happen, because you gave us a closure that this was supposed to happen. And we could see all of the entire hospital try for, the child. You see the director sir was also, continuously trying, like he's the head, like he was the HOD pediatrician, our neonatologist. So everyone was very involved with the family. So the hematologist, everyone was there. And he said, ma'am, just imagine, we are people who never thought that so many doctors would help our children. And here we have a diagnosis. We actually had a closure. And for the last baby, we knew this would happen. So we were prepared. And we might adopt another child, but at least we know what happened. So, here where we couldn't save the child, you see the emotional burden where, there was a diagnosis, but we could do nothing. And but still, this family took it in such
Family
a
took it. Yeah.
in a very different way. Uh, there's another family. I'll give you an example. So this girl's mother had breast cancer, and she knew it was BRCA. And she was quite educated. She was working in an IT company. So she came to us and said that, my mother is BRCA positive. The oncologist has asked me and my sister to get tested. So I want to test. So we asked, can you bring your sister in? So the sister also came, and the sister was like, no, no, I don't want to get tested. It's like a ticking time bomb. I don't want to get tested. But this girl was hell bent. No, no, it's actionable, early detection and all of that. So, and she convinced her elder sister also to get tested, and both of them got tested. Unfortunately, the sister who did not want to test uh,
It
got
was.
it positive, and the sister who wanted to test had it negative. All right. And the guilt this second sister felt, because the elder sister already had a daughter, and now she
She
was
had to test,
shit
get the
worried.
doctor tested at some
Yes, and
point.
she was scared about herself, and her whole life turned off because, in the first place, she was not ready. And though, I had told her, don't test if you are not ready, go to a psychologist first, think of yourself, you still have time, just go on for the surveillance. But still, her little sister forced her and she tested. All right. The guilt, this little sister had was a separate level. In fact, I sat little with the elder sister because, eventually her husband came in, her in-laws came in, and they took it very nicely, and they comforted, and she seemed to be all right with it. And we placed her through all the surveillance and whatever needed to be done. But the younger sister with a negative report, he was like, I brought this to my elder sister. So you see, the emotions are huge when we are counseling, and I guess this is our daily bread. This is what we face daily, and it's just not about giving a diagnosis. It's too human, I would say, and hence, sometimes like few days it's too heavy for us also because these things are something, human emotions are so varied that you cannot write it as a protocol, and so it has to be taken one by one. Yes.
I think that, I mean, with those two examples, you've kind of really zeroed in on
Yeah.
on the need for genetic counseling, actually.
Yeah.
Because, because otherwise it just feels like it's all science, but it's really the how it impacts the families is really what came through in both those examples. And
So one of the reason I got drawn to this field was that, here science was too human.
mm,
Like I still love the fact that, you get to see so much of human emotions. If I ever retire, I would write a book on it. So yeah, it's too much of human. It's too much of a spectrum that you see actually.
and since you were talking of especially for things like, and I know the focus of this session is on rare diseases and not so much on cancer, but when it is a family, is there a minimum age before which they are
Yeah.
asked? Yeah.
So it is just not for cancer, it's also for rare diseases. So
Mm.
normally, adult onset diseases, if we are talking about, then we normally wouldn't like to test a child.
Right.
So India still does not have any rules as such. We follow the American and the European rules. But if we are looking at it, then the American and the European rules say that certain adult onset disorders we cannot test prenatally, or we cannot do a testing on a child. We only test things which have a sort of implication, or where we can do an intervention if it is a child. Others, which like, Huntington, Parkinson's, there are many such conditions, many cancers also.
Right.
They are normally not advised to be test prenatally or as a child. We will wait for a
Them to
carrier
be.
status,
Okay.
say it's a female child, and we want to see a carrier status, or a male child and a carrier status. These would be tested later on when they come of age, or when they are planning a child. Yes.
So the coming of age you treat as 18 or 21 or 16?
So India does not have a rule, but yes,
Mhm.
if you are looking at other countries, it's above 18. Yes.
Above 18. Okay. Okay. All right. I think we have gone over your time. Any final thoughts or message to the audience?
My first take would be, we are talking about rare diseases, but rare diseases are not rare. They are happening in the family like yours and mine. And unfortunately, when it does not happen to us, we feel that it is too far to us. And we do not really, we listen to these as stories until, one day we realize that we are also part of that story. So I would first suggest that, if you are there, like you are planning, then it's better that, you talk to your doctors about this. And if your doctors feel, they will probably put you with a geneticist. You don't need to have a condition first to see a geneticist. You can always come and speak if you speak to your gynecologist or anybody. For
So,
families who all,
sorry, clarify on that. Are
yeah.
you talking of preconception counseling as
Yeah,
well? Yeah.
yes,
Okay.
yes. I believe we are of the age where the world is doing preconception counseling, and India, though we have guided them for thalassemia and SMA,
Mhm.
but in families where there is history, and they can just explore, because the
Right.
tests are available and they are not that expensive at the moment, and they can definitely explore. There are
Right.
certain limitations to what I am saying, and those limitations are why you need to see your doctor, and you need to see a genetic counselor, so that those can be explored and understood and then gone forward with. The other part would be, even with families who have people with rare genetic conditions. One very important thing is, sometimes we lose hope,
Yeah.
because we feel that there's nothing beyond this, and life is not beyond this. But we also have examples from this rare disease community itself, where people have sort of rearranged their lives around this particular
Right.
condition, and not made this condition their identity. So and even with lethal conditions, like with life limiting conditions. So I always feel that that hope is extremely important, that fight is extremely important. And if you see that most of our rare disease warriors, the rare disease patients, actually have that fight in them. Like, we get so bogged down at times, but these individuals, they are so brave that they actually would go, like, it's like, their fear is gone. They just have hope. So
Right.
I would say that's a very important learning. And because of that, they should also not work in silos, and
Mm.
they should always reach out to the community, so that that community can pressurize policy, pressurize science, pressurize technology, pressurize pharmacies to come up with more cheaper drugs, more usable interventions. And they are the ones who are changing the whole scenario, if we are looking at it. So
Right.
I would say that it's a very important part of it, and very soon I believe that rare disease will not be termed really a rare disease, and it will come to the public sector as well. And if that comes, the acceptance will come up. And
Mm.
talking about science will not only help, we also need to include these people socially.
Right.
And if we don't do that, then even if we have so much of advances in the clinics and in interventions and in diagnosis, what will you do with a diagnosis? Your diagnosis will need intervention. What will you do with an intervention? It will need a cure or a management. If they are saved and if they are managed, what will happen to these children? They need to be
Right.
in the society included. But unfortunately, we are not seeing the entire part. So this is just not about doctors and patients. This is about the community at large. And I feel it's time that we start speaking about inclusion very strongly, so that these individuals whom we are able to change the natural history, have a space for themselves and with dignity, and they can stand up for themselves.
Thank you. Thank you, Dipanjana. Couldn't have sent it better. I think today's session, we've covered a lot of stuff. We've talked of the science we've talked of the challenges of accessibility to the science as well. It's a huge issue still. We've talked of the roles of other healthcare professionals because, often in our context, we only look at the treating doctor as the doctor, but there's actually a community of other professionals who add value, as well as Dipanjana said, patient groups, advocates, etc. And we all need and that's why we actually work on how to bring all of these people together to influence policy making and to drive change in healthcare systems and strengthen healthcare systems. And I think the last I would say that we've really understood the role of the genetic counselor in this session, thanks to you, Dipanjana, and really to kind of you've really humanized science. When you first started those 2 or 3 slides, it was like, okay, this is going to we'll have to find a way to make this more human, but we've ended it with very wonderful examples that you've shared of people and how these things impact families, and that's really the crux of it. So thank you so much for joining us today and sharing your expertise with our audience.
Thank you so much. Thank you.
Thank you.